The next speaker is Dr. Giac Consiglieri. Giac is the director of our neurosurgery program at Santa Rosa Memorial Hospital. He's going to talk to you about maybe two extremes of neurosurgery, the delicate brain and spine tumor program that he operates on, as well as the management of low back pain for the primary care physician. A little bit about Giac. I feel privileged to call him a colleague and a personal friend. Giac is really a homegrown rock star. He grew up here, went to medical school down at UC San Diego, Revel, and got his master's down there. And went to USC Medical, no, did I get that right? Yeah, USC Medical School, where he graduated with the highest honors. And after a one-year surgical internship, he did 6 years of neurosurgical training at the Barrow Institute in Phoenix. You know, Giac, along with his wife, actually every member of the neurosurgical team at Santa Rosa Memorial Hospital, I was reminded of an ad that used to be done by a mortgage company that now is no longer in business, where they would talk about all the stuff that they would do for you, and at the end they would say, well, and we're nice people too. Well, Giac is one of those guys that he's a brain surgeon, and he's a nice person too. And he gives a great condensed TED Talk type lecture, so I hope you appreciate it. And Giac.
All right. Well, thanks for having me. I'm happy to be here. I had the opportunity to be here, I think 3 or 4 years ago, and when I thought about what I would talk about today. It kind of brought me back to my last national neurosurgical meeting, where I went for 4 days and I attended, hours upon hours of talks a day. And you come out of those meetings sometimes realizing that maybe 5 to 10% of what you heard was actually meaningful and applicable to what you do on a daily basis. And so in putting together today's talk, it's not heavily loaded with research. I'm not going to show you a tremendous number of randomized studies, that sort of thing. But I hope that this talk will be meaningful to your daily experience with patients, either in the primary care setting or in the emergency room, and really creating kind of a black and white way to treat what is sometimes not such an easy problem. And so just a little bit, no disclosures or conflicts. I'm going to talk about really two topics. One is the neuro-tumor board that we've kind of developed over the last 6 months here in Santa Rosa. And then I'm going to focus primarily on the management of back pain and sciatica. One slide at the end on cervical myelopathy. So, as Tuck mentioned, my wife, Rosa Germain, and I came to town about 5 years ago. I am from Santa Rosa, and really the driving force for coming to the area was to be back where I wanted to be and with family. And it was a little bit of a daunting task to come and kind of build a program that essentially, with the departure of some of the neurosurgeons and the retirements, was really kind of starting from scratch. And it's been a wonderful, meaningful experience, and we're quite happy here with what we do. Our practice is focused primarily on brain tumors, degenerative spine, and then trauma. So I'd say we do about 30% cranial, about 70% spine. Obviously, the bulk of the spine is degenerative spine, maybe about 25% are spine fractures. So this slide only has one important word, and that's conservative. If you're dealing with a neurosurgeon and you're a referring doctor, you're looking for someone who's conservative. I think coming into practice 7 years ago, one of the daunting things is that there's really no one looking at what you do or who you operate on or who gets a fusion or how many levels there are. I mean, you have to justify, insurance approval. But really, there's a tremendous amount of kind of moral weight in terms of what you do and why you do it. And so I think in terms of looking at a conservative surgeon, that's what I strive to be on a daily basis. So doing the right thing, doing what makes sense, and doing what's appropriate. Curtis, he looks very young. He joined us a couple years ago between now and our last talk. He is a fully trained neurosurgeon. He focuses most of his practice on the inpatient setting, but he's been a great addition to the group and just a wonderful guy. Okay, so in terms of neuro-tumor board, when we came to town, I'll kind of skip to this slide, essentially no brain tumors being done here. So essentially everything from Sonomas, Napa, Lake County, Mendocino County, everything was kind of shuttling by Santa Rosa and going down to either the city or somewhere in the South Bay or East Bay. And upon our arrival, we really set out to build a program to treat these patients and offer a local option. Obviously, a place like UCSF is kind of state-of-the-art worldwide in terms of their treatment of brain tumor and in terms of their clinical trials and their research. But really, for the most part, the convenience for a patient to go somewhere local, have their care which is appropriate done in that setting, and then have the kind of adjuvant treatment at big university centers as needed, we thought would be a meaningful benefit to the community. And so part of this was first kind of gaining the trust of our colleagues, our oncology colleagues, our radiation oncology colleagues. And then ultimately we kind of had a vision of setting up this tumor board. And so this is a monthly meeting where all the physicians, they take this time out of their own kind of work and personal life. We have our neuroradiologist, primarily Bob Feiwell. We have pathology, Paul Wasserstein. And then we have a cohort of our oncology, radiation oncology, and neurosurgical colleagues, which meet and kind of review a cohort of cases between 5 and 10, which have kind of accumulated over the last month, and really deem what are the most appropriate treatments in terms of are there potential studies that the patient would be a candidate for, what kind of radiation is appropriate, are they just followed conservatively, at which point do we re-image, and those discussions. And so, you know, this is a nice example. This bottom slide is a gentleman who is up in Lake County, nice rancher, and basically had been diagnosed with kind of acute onset or kind of rapidly progressive dementia. Incidentally, he had had an MRI 3 years before, which had shown a small meningioma, but it had switched providers, and that had kind of all gotten lost in the mix. So in any case, as part of that workup, he did get an MRI, and lo and behold, there's this large meningioma. Got him on the OR schedule. A couple days later, took it out, and he's doing well. His wife's the thing that she noticed most about his changes prior to surgery is that he had become a very soft and gentle soul. And although they were quite thrilled with his outcome, he was in the hospital a couple nights, went home, she was quick to point out at his 2-week visit that he was back to his ornery self almost immediately. So really, we treat kind of the spectrum of tumors, both primary and metastatic brain tumors, spine tumors. This is a woman who I know well. I actually treated her back in 2014. She had spinal cord compression, and I did a surgery to decompress her spinal canal. At the time, she was noted to have a very, very, very small meningioma lower down in her spine. She comes back to see me about 3.5 years later with progressive symptoms of hand clumsiness, balance difficulty, etc. And she's developed adjacent level disease, which is stenosis kind of up here at C3-4 above her previous surgery. And that meningioma that was lower down in the spine had dramatically enlarged. So you can see this meningioma, which is pushing on the spinal cord at T1-2. And you can see here spinal cord in the front, and then the spinal cord, tumor in the front, spinal cord draped over the back of it. So actually just last week she underwent a fairly complex surgery where her fusion and her decompression was extended up high. Normally for a tumor like this, you could simply do a laminectomy and take out the tumor. Unfortunately, given its location relative to the spinal cord, it was a more extensive approach where the entire pedicle, part of the vertebral body, was removed to really give me that lateral approach. And she's doing quite well with almost immediate improvement in her hand function and balance postoperatively. So again, kind of the spectrum of lesions that we address are anything from primary brain tumors, gliomas, to meningiomas, spinal tumors, metastatic tumors. And what I've been most impressed with is the fact that our radiation oncology colleagues, which include Fred David, Cindy Sharfin, and Anna Paulson, who's a recent addition from UCSF and who has an interest, especially in stereotactic radiation, and we'll talk later today, is that both the radiation oncology colleagues and our oncology colleagues bring with them to almost every conference a tremendous wealth of knowledge in terms of kind of the most current research, the most current studies. It's actually shamed me a little bit in terms of now I'm starting to do a little research ahead of Tumor Board and try to bring forth some things because they are on the cutting edge in terms of their knowledge base. And I think if you're going to establish an entity like this and you're going to try to make an argument for the treatment of this sort of patient condition when you're next door to a major place like UCSF or Stanford or UC Davis, you really have to have that kind of commitment. I would say that there are certainly patients that we send to some of these academic institutions for an initial consultation, mainly because we want to make sure that they have access to any active clinical trials or potential involvement with treatments that we maybe don't offer here in the area. And so this has been really exciting for me in kind of what I envisioned when I came here and kind of where we're at 5 years later. I'll just give a quick update. So the spine service line is something that you may remember from my previous talk, but basically, in summary, it's a collaboration of all the spine surgeons at Santa Rosa Memorial Hospital and kind of working together to improve kind of the patient experience and patient outcomes. So in the interval, 3 years since we last saw each other, we've implemented an infection bundle, which has a number of components to it that basically address decreasing infection risk in the perioperative period. We've instituted a perioperative pain control bundle. We've standardized our order sets. And since 2016, we've added Tia DeSoto, who's here today at a booth. And she has been absolutely amazing in terms of enhancing the patient experience at the hospital. She essentially gives a couple times a month a preoperative spine class in which all patients who are on the schedule are invited to really, it puts them at ease. It gives them an idea of what their experience in the hospital will be like and kind of what their postoperative expectations are. And she has been, we treat a very challenging patient population, not only here in Sonoma County, but with respect to the outlying counties as well. And if I have a patient that I know is going to be a difficult placement issue or has a difficult home situation or, for crying out loud, literally cannot get to the hospital, she's just been absolutely instrumental in kind of facilitating their care and really helping, especially with tying up some of the social loose ends on these patients. So low back pain and sciatica. Again, I was trying to think of something that would be really pragmatic and useful for some, if not all of you, in your daily practice. And what I do and what I've tried to do since I've been in practice is really create a black and white paradigm out of something that is really gray. And for many people, potentially, if not all, maybe one of their least favorite things to deal with on a daily basis in the office. And so as I thought about this, I break especially lumbar spine patients up into 4 essentially distinct categories, although obviously there is some overlap between each and all categories of lumbar spine problems. And that's kind of how I will address them as we move forward. So isolated back pain. So really no leg symptoms at all, simply back pain. Isolated lumbar radiculopathy. So really they're not complaining about anything in their back, but man, the pain that's radiating down through their buttocks and hip and leg is just intolerable. And then the third component is one that really has a fairly balanced distribution of not only leg symptoms, but also back pain. And then a fourth category, which is neurogenic claudication. Now, again, there's going to be some blurring across these categories, but your neurogenic claudication patient is going to be your patient who's in their, anywhere from 50s, 60s, 70s, 80s, who they notice just this dramatic change in their activity level and their stamina and their ability to stand and walk from where they were 2 or 3 years ago to where they are now. So these are the patients who do have a component of back pain. They also have a component of leg symptoms, whether they be fatigue or numbness or sometimes even burning pain. But really with the common complaint of everything is made worse by standing and walking, and everything is proved by sitting down and leaning forward. And so if we kind of approach the lumbar spine by looking at patients in these 4 categories, when we talk about management, well, what is the management? So what are the 5 things to run through your mind when you're presented with someone like this in clinic and you've got 10 minutes to figure it all out? So medications, imaging, therapies, and then do they need a referral? And if that referral is necessary, is it to pain management or is it to neurosurgery or spine surgery? And so we'll start with isolated back pain and we'll kind of go through each of these 4 categories with those 5 management points in line. And so your differential diagnosis, 90% of these patients are going to be patients with either degenerative disc disease or spondylosis, which is simply facet arthritis, or maybe spondylolisthesis, some slippage between the bone, or spinal stenosis. And then you're going to have a few outliers. So these are going to be primarily your elderly patients who are osteoporotic, who can get a compression fracture from simply sneezing, someone who's got a tumor in the spine, maybe a cancer history, osteomyelitis or discitis, and then maybe the young person or middle-aged person who was lifting a box at work and simply threw out their back. And so this is kind of the differential to kind of run through your mind as you deal with someone who presents with isolated back pain. In terms of medications, I think we're all kind of experiencing a fairly similar experience with the climate around narcotic medications. There's really no role for acute narcotics in my mind for someone who presents with an exacerbation or worsening low back pain to start. Obviously, NSAIDs, acetaminophen, muscle relaxants are reasonable things, for the patient to kind of start when you're looking at back pain. When we're talking about imaging, plain films, if you have a suspicion of one of those other issues, such as a compression fracture, or if you're concerned about osteomyelitis, maybe in the poorly controlled diabetic or the IV drug user, or if you're looking to identify something like spondylolisthesis or a structural issue, plain films are fine to start. Will that patient, are they appropriate for therapy? Absolutely, they should be started with therapy. Pain management referral, probably not right off the bat. Obviously, if it's someone who comes to you as a new patient with kind of a heavy narcotic past and you're trying to juggle these medications, then the pain management referral probably is appropriate. I can at least speak to the 7 or 8 pain management physicians in the area and the surrounding areas, and I can tell you just from reviewing their documentation over the last couple of years, all of those patients, when they get into pain management, are kind of set on a track of minimizing narcotic use, decreasing narcotic use, transitioning off narcotics. And so if you're dealing with the situation then certainly pain management up front is an appropriate referral. And then neurosurgical referral, I mean, the frank answer is no, but the reality is that these patients, for the most part, at some point usually want to speak with the surgeon. In my practice, I've gone through varying ways of how to deal with this just because there is only so much time and only so many spots. And so usually my office will call the patient and be like, the physician reviewed your imaging. He's certainly happy to see you and review them, but there's probably going to be a little bit of a longer wait than you would otherwise normally expect. And so that's kind of how I deal with it, and my colleagues typically do as well. Oh. Grabbed the wrong one. So additional imaging, is additional imaging beyond x-rays necessary? So when we talk about back pain, well, back pain and. So if a patient presents with back pain and they have some sort of leg component or if they have some sort of neurologic deficit, do they have other systemic suspicious symptoms? Do they have fever, white count, et cetera, history of cancer, then yeah, that patient might be someone that you think a little bit outside the box and say, well, do I need to image? Do they need an MRI? Do they need a CT scan? This is an example of a patient that is kind of a good example of what we deal with in our practice just based on the unique factors of where we are and where patients are coming from. So this gentleman lived on a goat farm deep in West County. And when I say on a goat farm, there were no buildings. It was just him on a goat farm in a lean-to with his very trusty cat by his side. This is a nice guy. He kind of had worked odd jobs his whole life, really no past medical history. He presented at the ER 3 times in a row over the course of about 3 months. And if you look at the x-ray on the left there, you can see that there is something going on at L1, and it looks a little bit odd. Maybe you could just think it's a standard compression fracture. You look a little deeper, you see that really the pedicle's kind of missing, et cetera. But anyway, he ended up being sent out a number of times, and ultimately on his 3rd visit back, essentially couldn't walk because his symptoms had progressed, and now he had leg pain, and he had leg weakness, and he had leg numbness. And so what do we see here? Well, we see that we've got clearly some sort of process in the vertebral body of L1. This is an MRI that shows a large expansile lesion. It was associated with severe spinal stenosis. So ultimately, he went to the operating room. He had a complete decompression, and in the setting of basically a vertebral body that's gone, he had a fusion above and below. This was plasmacytoma, isolated plasmacytoma. He underwent radiation therapy and has ultimately done very well. He's back to his goat farm, tending his goats, and with his trusty cat. So it's a situation where 99% of the people with back pain you're going to see, they're just degenerative low back pain, and there's really not. But you kind of always have to think about what else could be going on and what other imaging studies may be necessary in the setting of a picture that's not quite making sense. So moving on from isolated back pain to isolated lumbar radiculopathy. So this is the story that you will classically hear is, well, a few months ago I had this twinge of back pain and my back bothered me for a couple days, and then boom, 3 days later, horrible leg pain. So the vast majority of these patients are going to be lumbar disc herniations. Lumbar foraminal stenosis is more of a degenerative process that occurs over time and certainly can cause lumbar radiculopathy, but for the vast majority of patients that have lumbar foraminal stenosis, relatively few actually have lumbar radicular symptoms. Patients with central lumbar stenosis can present with isolated lumbar radiculopathy. And then you have kind of much more rare entities, such as a spinal tumor causing lumbar radiculopathy, shingles, femoral neuralgia, or myalgia paresthetica. And so in terms of medications, I'd say that the big change I've seen just in my years in practice is kind of the aggressive use of gabapentin and pregabalin and NSAIDs. I will routinely see a patient like this in the office who hasn't been started on gabapentin and start them that day. It's a good medication. I think you're all familiar with it in terms of its use in diabetics, et cetera. But about 10% in my experience get some drowsiness, so I usually tell patients to start it at night or on the weekend. But it's been very effective in my practice in terms of mitigating pain and trying to get the patient on a course that will allow them to avoid surgery. So in the absence of a neurologic deficit, which we'll talk a little bit more about shortly, or intractable pain, and you all know that intractable pain patient. There's the one patient who comes in and says, yeah, they're sitting there comfortably, they describe their radiculopathy, and you have a nice chat about it. Then there's the patient who can't sit down, and they can't lay down, and they can't stand up, and they're sweating, and they're walking around the room, and they haven't slept in 3 days. And in that patient, imaging early is reasonable. In the patient without a deficit whose pain is tolerable, waiting 6 weeks is completely appropriate. A lot of these patients, their symptoms will resolve with time on their own, and ultimately will never get an MRI and never get surgery. Physical therapy, I'm always a little mixed on this for someone with an isolated radiculopathy. I don't want this patient going to PT and being worked aggressively with their core and with all kinds of manipulation and aggressive stretching. If they want to go to PT and have some soft tissue massage, some cold TENS unit, et cetera, that's fine. But when I see someone with an isolated radiculopathy, I rarely send them to PT for that very reason. I don't want them to exacerbate their current condition. Pain management is an appropriate referral. Usually if the pain's there for greater than 6 weeks, probably they're an appropriate candidate for an MRI and or pain management referral for epidural injection. And then neurosurgical referral, yes, is completely appropriate. The one thing I would say is when we talk about neurologic deficit, if you have a patient in your office and you identify a neurologic deficit in the setting of an acute radiculopathy, feel free to get on the phone and call the office. I mean, there's always one of us around. You can always get someone on the phone. We can always see that disc herniation as a referral that's going to be seen by us in a month. And if they've got a foot drop or whatnot, you can always find a space to squeeze them in. So don't ever hesitate to do that. So when we talk about red flags for isolated radiculopathy, we're basically talking about neurologic deficits. And so it's not just a foot drop. I mean, obviously, foot drop is probably the most common neurologic deficit someone will present with. Foot drop can be associated with either the L4 or L5 nerve root. But you also have to think about things like quad weakness. Oftentimes patients with a higher herniated disc, such as L2-3 or L3-4, will complain of quad weakness. It's not easy to pick up on it, but they might complain that their leg is giving out every time they try to plant on it. And then for plantar flexion weakness, which is going to be primarily seen in an L5-S1 disc herniation, it's very difficult to tell the difference just by having the patient push down on your hand. So I usually make that patient get up, I make them stand on the balls of their feet, and then I make them stand isolated on either side. That's a very sensitive exam to pick up on gastroc weakness or plantar flexion weakness. And then I think we're all familiar with caudate equina syndrome. So if you've got a patient, especially a lung patient, complaining of numbness, tingling in the genital or perianal region, overflow incontinence, loss of rectal tone, obviously that patient needs to go to the emergency room right away. What I can tell you is that there's a lot of good literature out there on how to treat a lumbar disc herniation. There are studies that are going back to the 60s and 70s that will kind of tell you that in the absence of a neurologic deficit, if you wait 1 or 2 years, most of the patients who have a lumbar radiculopathy and a disc herniation, with or without treatment or with or without surgery, will ultimately end up at about the same spot. And I essentially tell all my patients this when they come to see me and when we begin our discussion. That being said, there's also plenty of evidence that shows that if someone fails early conservative management, so 2 to 3 to 4 months of conservative management, then ultimately that patient will do very well with a microdiscectomy, and their pain will be alleviated much earlier, their return to work will be earlier, their return to activities will be earlier, they'll be happier earlier. And so this is just a study, this is a meta-analysis that came out last year, looking at 14 comparative studies, 8 randomized trials, and basically the conclusion is that lumbar discectomy is more effective than conservative therapy in alleviating symptoms in patients that have always failed initial conservative management. So I think if there's one thing to take home, it's that in the absence of a deficit, give the patient a chance to get better on their own. And ultimately, if they don't get better, whether that's 2, 3, 4 months down the road, then surgical microdiscectomy is a good treatment for them, and they probably will do well. I send the vast majority of my lumbar disc herniations with radiculopathy for an epidural injection. I feel like it's the one indication for epidural injection that, in my mind, is very sound and very solid, and I see patients dramatically improve with injections. I know that a lot of injections are done, and I'm sure you see these reports of 3, 4, 5 injections a year for all kinds of symptoms, but in the isolated lumbar radiculopathy with a herniated disc fragment, that is a perfect patient for an epidural injection relatively early. This is just another study to give you a little bit more evidence. So this is looking at a cohort of 2 groups of patients. There were about 150, give or take, in each group. They had one group in which they did early microdiscectomy, so microdiscectomy within 2 weeks of seeing the neurosurgeon versus conservative management. And what they found is that early surgery achieved a more rapid relief of sciatica than conservative care, but outcomes were similar by 1 to 2 years. And what you have to kind of dig into the paper a little bit to see is that of the 141 patients that were assigned to long-term conservative management, 55 out of them converted over and ultimately got surgery. So again, emphasizing the importance of a conservative approach up front, but that ultimately, if they fail up front conservative therapy, they'll do well with microdiscectomy. This is one of my favorite stories of all time. This 19-year-old absolutely mass of a man, all muscle, 6'3", 200 pounds, who presented in my office on crutches. He'd had intractable bilateral leg pain for 2 months. He'd been sent to physical therapy 3 times without an MRI. He ultimately had to pull out of classes at the JC because of pain. He was eating Norcos every 3 hours, and he was just miserable. So you can see on this MRI, he's got a very large disc herniation at L4-5 in the setting of probably a congenitally narrow canal. I took him to the OR, I think a day or 2 later. This is just a little diagram of a minimally invasive microdiscectomy. Took him for a microdiscectomy, and that afternoon he's racing up and down the hallways. And in spite of all my warnings about disc herniation and this and that and the other, at 2 weeks he was back to playing tennis, playing basketball, re-enrolled in school. So if you have someone that, I mean, he could not even raise up on the balls of his feet. He was just stuck to the ground. So someone like that is not appropriate for PTA as a first line therapy, and really an early MRI is appropriate. So lumbar radiculopathy with back pain. Again, it's the same differential diagnosis for low back pain. The treatment paradigm in terms of management is more or less the same, maybe adding some gabapentin along with NSAIDs. Again, plain films are reasonable. MRI at 6 weeks in the absence of a deficit. Yes for therapies, yes for pain management, and yes for neurosurgical referral. The literature is all over the place on lumbar fusion, and I could give a neurosurgeon focused talk on who's appropriate for lumbar fusion, and then we could talk for hours about which type of lumbar fusion, from the front, from the side, from the back. Really not appropriate for this audience. What I would tell you is that if you're seeing spine fusions in patients that have spondylolisthesis, they have spinal instability, they have central stenosis, they have severe foraminal stenosis, they have back and leg symptoms, then probably you're dealing with a relatively conservative surgeons, and your patients are going to ultimately be pretty happy with their spine fusion experience. If you're seeing a lot of lumbar fusions for patients that have degenerative disc disease only, they've got some arthritis, there's no central stenosis, there's no foraminal stenosis, you're going to have a lot of patients that basically are where they started. They're not going to get better, they're going to still have back pain. And so, that's just a very, very casual, kind of off-the-cuff rule of thumb in terms of who's appropriate for lumbar fusion. This is a case that remains one of my favorite. I saw her when I first got to town in practice. She came to me via Giac Consiglieri, who I'm not sure if he's here, but she was a delightful lady, but really a train wreck medically. She was morbidly obese, rheumatoid arthritis, smoked, and she had this severe spinal stenosis at L4-5. And we kind of had a heart-to-heart in our first meeting, and I just told her, I said, you're gonna do poorly with surgery if we operate now. And with a lot of aggressive kind of counseling and therapy, she ended up losing 40 pounds. She got her blood sugars well controlled, got her hemoglobin A1C under 8, and then we got her signed up for surgery about 4 months later. And so ultimately she had this lumbar decompression and fusion. did fantastic. And at her 2-week visit, she is someone who literally was not standing for more than 5 minutes, and she was walking a mile a day. So it's just, no one wants to hear lumbar fusion. Everyone knows 50 people have had horrible experiences, but if you select the right patient population, patients do well. I feel like I lost my ability to, oh, okay, sorry. So neurogenic claudication. This is something that's going to come across everyone's plate fairly frequently. So elderly population, really everything is made worse by standing up. So I ask my patients 3 to 4 questions in the office. How long can you stand? How long could you stand 5 years ago? How long can you walk? How long could you walk 2 to 3 years ago? Do you drape yourself over the shopping cart when you're at Costco or the grocery store? And if all those questions are overwhelmingly positive, that patient has neurogenic claudication, and that patient should get an MRI then, and not be sent to PT, and not be sent to pain management. The differential diagnosis, we could create a long one, but a lot of these patients have overlap with peripheral neuropathy, so they all want to know if their numb feet in the diabetic population are going to get better. So there is some overlap there, generalized weakness, et cetera. Again, when we look at our 5 management modalities, you can start them on gabapentin. Some patients get some benefit. In the real elderly, maybe it makes them a little sleepy. It's kind of 50-50. When you get the MRI, I will routinely see patients that are referred to me that have a paper copy, a printout of their MRI. And there's all these circles and stars under severe spondylosis, severe foraminal stenosis, severe degenerative disc disease. Really, the one term that you're looking for to tell you whether this patient should be seen sooner than later is severe central stenosis. That's really the thing in a patient that's going to determine whether they're an appropriate surgical candidate. Therapies are fine if you're looking at someone who's maybe a little deconditioned and you'd like to get them in a better state before surgery, then PT is reasonable. Injections may provide some relief, but I usually tell patients that if it's not a good time for surgery, get an injection. You may buy yourself some time, but ultimately you'll make the decision for surgery. One line that every lumbar stenosis patient gets from me is, the decision for surgery is ultimately yours. I can tell you you're a reasonable candidate for surgery when you feel like your activities of daily living and your mobility and all those things are limited to the point where you're no longer happy with your quality of life. You make the decision, we'll do surgery. This is just one article I pulled looking at epidural injections for spinal stenosis. Really, there's little to no symptomatic improvement on the relief of patients with respect to their ability to walk. So this is really why I don't push the agenda with an epidural injection, although most of these patients who come to me with lumbar stenosis have had epidural injections, and will all tell you that they get a little bit of relief, but it really doesn't do it. I include this slide only because this is an excellent overview article, and if you want to have something on hand, on your computer or whatnot, this just came out in 2019, and this is something that, may help you in your own clinical practice. So just an example, I'm running out of time, so all I can tell you is he's got bad lumbar stenosis. We did a laminectomy, he went home the next morning, and he was walking better. One slide on cervical myelopathy. I feel like cervical myelopathy is something that's very easy to miss on elderly patients, and it's because, number one, a lot of them think that worsening balance as they age is normal and it's just part of the process. They attribute hand clumsiness, difficulty with fine motor movements, dropping things to arthritis in their hands. And these are patients where if you have someone who's really off balance and they have some subtle arm symptoms, you really should at least have the thought of cervical myelopathy in your mind. And I'll spend a minute on these 3 cases that have all come to me in the last 3 weeks. The lady on the left was treated at a hospital within our referral region. For 3 weeks, she was diagnosed with Guillain-Barré syndrome, never had imaging of her neck, and presented to me 6 months later with an MRI of her lumbar spine because they were worried about neurogenic claudication. I examined her, got an MRI the next day, and you can see that her spinal cord is completely smashed. And although she may have had concurrent Guillain-Barré, I think that her problem is in the neck. Second patient has had symptoms of inability to walk without a walker. She's 50. Inability to use her hands to eat independently for the last year. She was referred 10 months into her set of symptoms for an EMG study to rule out carpal tunnel syndrome. She was seen by the neurologist here in Santa Rosa. Immediately an MRI was ordered, and she was found to have this, and she's on the schedule for Thursday. She's on the schedule for next Thursday. And this is a gentleman who's 82. He's been in an assisted care living facility for 15 years because he can't walk independently and he can't use his hands independently. He's never had his neck imaged. Well, he got a new provider who examined him, saw his florid myelopathy, got an MRI of his neck, and his spinal cord, it's a little difficult on this imaging, was his spinal canal was decreased to about 3 millimeters. So in any case, took him for decompression. He went to our inpatient rehab, and within a week, his gait was improved, his hand function was improved, and everything. So just keep it in the back of your mind when you see these patients who have these subtle symptoms that don't totally make sense, don't totally fit together. All right, that's me and my family. Any questions? Sure.
What do you do with people with degenerative joint disease who also have scoliosis or some other curvature of their spine?
Okay, great question. So chiropractors, I work collaboratively with a lot of them in so much as a huge percentage of patients I see are working with a chiropractor. I'm essentially okay with anything they do in the lumbar or thoracic region. I'm fine with any soft tissue deep massage in the neck. I'm usually not a huge fan of massive adjustments. But that's really a bias in so much as I see the 1 or 2 disasters a year where someone gets a vertebral artery dissection or a spinal cord injury. So for low back, I think it's perfectly appropriate. With respect to your second question, which completely just, scoliosis. So yes, this is a huge problem with scoliosis in terms of we have this aging population that may have a focal problem of stenosis in the setting of just a horrible scoliosis. And I think that we've got excellent colleagues at UCSF who do complex deformity correction. I end up screening a lot of those patients in my office first. If there's a small microlaminectomy that I can do to give them some relief of their leg symptoms, we typically lean in that direction. If their scoliosis has either dramatically progressed or is creating intractable pain, then I typically refer those down. Usually I use Dean Chow, who I know well, who's a good friend, but I typically will have them evaluated for a deformity correction. The problem with deformity correction is that typically it involves a massive surgery where they're being fused from their mid-thoracic spine to their pelvis, and those surgeries carry with them a morbidity of 25%. So it's a tough problem, but feel free to make it our problem to figure out.
What do you do neurosurgically for neurogenic claudication?
So neurogenic claudication in the absence of spinal instability or spondylolisthesis is typically just a microlaminectomy. So if it's a single level, I'll typically do it through a tube, which people like because they can show everyone their little incision. That's about 2 centimeters, and they can compare it to what they see in the magazines. It's just essentially drilling off bone on the back of the spine and taking the spinal canal and essentially taking the roof off of it. If someone has multi-level spinal stenosis, typically it's just a traditional linear incision, drilling off the bone, decompressing the nerve roots. I'd say the big shift in terms of technically how we do it now compared to how we did it 20 or 30 years ago is that we're very careful to preserve the facets. We take minimal bone, we use the microscope, we angle out to remove the hypertrophied ligament, and we really try to respect the integrity of the joints so that they don't develop iatrogenic instability down the road. In patients that have pre-existing spondylolisthesis or who also have severe foraminal stenosis, sometimes they're a candidate for fusion surgery, but we just kind of patient by patient.
The MRI that we're going to order, that's fine to just do it without contrast?
Yes, unless they've got metastatic disease and you're concerned about metastatic process, or unless it's a patient you're concerned about osteomyelitis. But in the absence of those two concerns, then just without contrast is fine. Open MRIs for patients are okay, but they're horrible quality. And in most situations, I will make them get a sedated regular MRI if I'm going to operate on them. But if you're just trying to diagnose a problem, they're appropriate, but they're just horrible quality compared to closed MRIs.
When would you get weight-bearing lumbar films or flexion extension studies?
So flexion extension studies, I would say if I've got someone with a spondylolisthesis that I really don't want to fuse, I'll get flexion extension films to rule out instability. I would say that flexion extension films are a little bit controversial. There are many surgeons that think they're useless and it doesn't really change their decision making. So I get them sparingly. But when I do get them, oftentimes I'm not necessarily comparing the flexion to the extension, but I'm comparing the flexion when they're sitting up to when they're supine on their MRI, because oftentimes you'll see a difference between the two. I think it's fine to order them on your side of things, but usually if I see an MRI and I'm concerned about something and I want them, my office will order them ahead of the visit. Other questions? All right. Well, thanks for your time.